Yeah, so it's live now.
Yes.
Perfect. So,
Just 1 second, Shilpa.
yeah.
Yes.
What if I say that there is a debilitating disease that affects 176 million women worldwide? That makes it 1 in 10 women. 73% people are not able to have a successful relationship because of this, and 83% of women are not able to live their life fully. They're not able to do their routine, regular day-to-day activities. And would you believe if I say that I am one of them? Hi, I'm Dr. Shilpa, and welcome to this talk on endometriosis. I got diagnosed with endometriosis in 2016, and when I was diagnosed, it was like a big shock for me. There were a lot of questions which were in my mind for which I was not able to find answers. That's how I and my friend Dr. Vimmi Bindra, we collaborated and we formed this group called Endo Crusaders with an aim not just to support the women, but also to create awareness and educate people about this silent disease called endometriosis. I'm honored today because I have a lovely panel with me on this forum who are going to enlighten us with different aspects of endometriosis, like the hows and the whys and whats of endometriosis. So let's begin this session. And I can't believe how good it's going to be. I'm sure people are going to be like, by the end of it, they are just going to be like knowledgeable about what exactly is this disease which people have not even heard of. So our first panelist today is my very good friend, Dr. Vimmi Bindra. She's a consultant gynecologist and laparoscopic surgeon at Apollo Clinics, Hyderabad. She specializes in fertility enhancing surgeries and endoexcision surgeries. She has a special interest in creating awareness about endometriosis and period pains in patients and doctors alike. And as a part of the endometriosis awareness program, she has also produced a short film called End the Silence. Hi, Vimmi.
Hi, Shilpa. Thank you so much.
Glad to have you.
Same here.
Our next guest on board today is Heather Guiden. Heather needs no introduction. She's a board certified patient advocate and a surgical program director at Center of Endometriosis Care, Atlanta. She's a central figure when it comes to endometriosis and women health, and she's been working endlessly for the last 30 years. She's internationally known as an expert on this disease, on this subject, and is working incessantly on behalf of the endo community. She herself is an endo warrior, and she has been working relentlessly on institutional policy reforms around healthcare, treatment facilities, increasing the awareness, decreasing the time taken for diagnosis, and increasing the access to effective healthcare. Hi, Heather. Glad to have you here.
Thank you so much.
Great. Our next guest on the board is somebody who's very important because with endometriosis comes a big chance of infertility. Dr. Seema Pandey, renowned IVF consultant and the director of Seema Hospital and Eva Fertility Clinic and IVF Center. She is the president of Azamgarh Obstetrics. She's the president of Azamgarh Obstetrics and Gynecological Society and National Executive Committee member of ISAR. She's the co-author of the book A to Z of PCOS and IVF. She has keen interest in endometriosis, reproductive health, and recurring pregnancy failures. She runs an NGO for Women and Child Welfare Society called Surabhi. Hi, Dr. Seema.
Hi, dear. Glad to be here.
I'm so happy to have you here.
Thank you so much.
Did you know 71 to 87% of women with endometriosis have pelvic pain? And who else would be better to talk about pelvic pain than Dr. Sally Sarrell? Dr. Sally is a physical therapist and she has designed pelvic physical therapy specifically for people with endometriosis. After being misdiagnosed for 23 years. I'm right, right? Sally, 23 years?
Right, yeah.
Oh my God, 23 years. Finally, Sally found a purpose and she did some amazing work for the endo community. She, along with Dr. Andrea Vidali, founded the Endometriosis Summit, which is the largest congregation of patients and practitioners in the US. She has also spearheaded I Care Better. She was a part of EndoWatt and is supported by Endometriosis Research Center and is an administrator of Nancy Nook. Hi, Sally. Welcome on
Hi,
board.
everybody. Thank you for having me.
Glad to have you.
Glad to have you, Sally.
Our pleasure. So let's treat our food like a medicine. To talk about this, we have with us Gayatri Venkatesh. Gayatri is a senior consultant dietitian with Apollo Clinics and Cope Clinics, and she has a rich experience in working in both Indian and international organizations. She has a broad exposure in her core competency of nutrition and dietetics. She specializes in therapeutic and anti-inflammatory diet, endometriosis diet, weight loss and diabetic counseling, and she also does create customized diet plans for well-being. Welcome all of you on the panel today.
Thank you so much.
Thank you, Shilpa. Thanks for the lovely introduction.
And for all the audience, we would love to have your questions typed into the chat box. We would get back to you with answers by the end of the session. So let's begin this session with Dr. Vimy. Vimy, first question that comes to my mind is, people don't know what endometriosis is. So can you please tell the audience what exactly is endometriosis and what is it? What are the symptoms that people have? When should they see a doctor?
Hi, Shilpa. Hi, everybody. Shilpa, endometriosis is affecting 1 in 10 women. And it is basically a presence of endometrium-like tissue outside the uterus. So there is a myth that it is, people say that endometrium is implanted outside, but this is not the endometrium. This is a similar tissue to the lining of the uterus for better understanding, but it has its own blood supply, it has its own nerve supply, and it invades the different tissues. It is basically a benign disease, but highly inflammatory. It produces a lot of scarring, inflammation, and it produces its own hormones. And it affects any race, age. It can affect postmenopausal women, fetuses, premenarchal girls, and men and animals as well. So this disease is affecting women a lot. Still, women need to know about it because misdiagnosis is the main problem with this disease. And delay in diagnosis is one of the concerns which bothers us, and women keep suffering for years together. And they keep changing doctors and keep doing scans, changing medications, and without any relief of pain. So pain is the main symptom which usually women come to us with endometriosis. Some women may be absolutely asymptomatic. They may not have any symptom, and they are diagnosed for the first time when they come to us for fertility issues. So diagnosing endometriosis on time and treating it on time is very important because it's a progressive disease. And medical treatment, if given, can reduce your symptoms, but definitely progression of the disease is not reduced. So on-time diagnosis and treatment is very, very important for endometriosis management.
Okay, so when a patient comes to you, what's the symptoms that patients generally give? And do you have stages in endometriosis?
Now, as I said, it is a complex disease. Symptoms differ from person to person. One girl can have severe symptoms and she may have a stage 1 disease. As you asked me, the staging of the disease can only be done by laparoscopy, and there is no clinical staging as of now for endometriosis, and clinical symptoms and staging on laparoscopy usually do not match always. A patient may be absolutely asymptomatic and can have a stage 4 disease and can have a frozen pelvis as well. So that's why it can be symptomatic or asymptomatic. And you asked me the symptoms for the patients. I kept this slide blank. The reason being, you can write anything on it. They have symptoms ranging from bloating to pelvic pain to infertility. They may have endobelly, what we call. They may have migraine, headache. Fatigue is one of the very important symptom. So these women sometimes may not have a evident disease on scans or clinical evidence, but the symptoms speak a lot. So we need to talk to them. Sometimes we can make them symptomatic. When we talk to them, when we ask, are you having this? Are you having this? We can get their symptoms out. Sometimes they don't understand what they are going through. So this is very, very important. So many people for endometriosis patients, they tell them that it's all in your head. So it's not like that. They are really suffering and we need to pay attention to them.
Absolutely. Absolutely. I mean, I can relate to it. It took me 15 or 17 years to get diagnosed with endometriosis. So I can imagine what it is like. So I would come to Sally. Sally, could you tell me a little about your journey, your story with endometriosis, and how did it come to you that you need to create so much that you're doing with Endo? And a little about the Endo Summit also.
Well, I just am very much an overachiever, everyone. So I have a little bit of a presentation. I am Dr. Sally Sorrell, and you can find me in the US, but really all over the world because I'm online pretty much constantly, along with my companion here, Heather Guidone. We never go to bed. We're always available because in our lives, no one was available to us. So we really try to be available to everybody else. Sorry, some technical issues. Let's see if why can't I? There we go. So I believe that no person should miss out on school, career, social participation, or motherhood because of pain and painful periods. And I also believe that I will not be silenced by my pain because in the United States, for sure, it is much easier for us as people with endometriosis to pack up our bags and sit there in pain and stay in pain than to actually seek help. Both these pictures are actually from my insides. You can see this is my sigmoid bowel endometriosis, and this is my own endometrioma. Unfortunately, before I was diagnosed, I had a 7-centimeter endometrioma rupture, and they still missed my diagnosis. So I was not somebody who knew to complain about pelvic pain or who knew to complain. I didn't even know sex wasn't supposed to hurt until I was much, much older. And I'm a pelvic PT. Let's make that clear. But I had mostly abdominal pain, bloating, constipation. I had a ton of food allergies, and I had all sorts of inflammatory gut problems that I spent my whole life trying to fix with diet. And while I'm a huge believer in the anti-inflammatory diet, I'm also a believer that no diet in the world is going to change either of these two things. So I also had a significant problem bearing weight on the side of one of my legs. So, and lo and behold, at 35, after I took to Google, because I spent just 1 year alone, I saw 14 gynecologists. I had 7 MRIs, all of which were negative, until I took one to an orthopedist I knew, and he said, did you ever look at the insides? Did you ever look at your insides? This is a mess. So it's amazing to me that an orthopedist could see that something was wrong, but that a gynecologist couldn't. At that point, I had my first excision surgery And unfortunately, it has not been a one and done with me. Of course, there was a surgical artifact left on that first surgery that within that cost me 3 more surgeries, that within an 8-year period degraded my entire abdominal wall. So it has not, I have been infertile. I lost an ovary without consent. I have been minimized. I had a doctor told me that I didn't have any pain. I was just retrograding into my belly. And by the way, that was told to me by a supposed excision specialist. I have lost jobs. I have delayed my education. I have severe financial issues from seeking care when care is not covered. And all of this made me sort of turn to Dr. Andrea Vidali one day when we were working in the OR. And I said, you know, people should see what good care really is. You know, we should showcase this. And he said, okay, how about we use the free conference room in the hospital? I said, great, then it won't cost us anything. And we planned this little tiny meeting. At most, we thought like we'd be pushing it if 100 people showed up. And within 2 years, we had 700 people in a massive setting for the Endometriosis Summit. We do our first days as workshops. So I hope, Guy, that you'll come maybe and join us for a workshop in our online summit next year, right? Absolutely. To talk about nutrition. We do the first day as workshops, and the second day we do really as a patient and practitioner town meeting, with the belief that the patients at this point know more than the doctors. And so we all have to be together, and we all have to be on the same page using our voices to move forward, because just accepting what we're told is not working for those of us in endometriosis right now. I am also, sorry to ramble, I'm a pelvic physical therapist by trade. And Dr. Schlippa, if you want me to continue, I have the rest of the presentation on pelvic floor, unless you want to.
Absolutely, because the next question that I was coming to was the same thing. Can pelvic floor therapy help with pain and endo?
So it's interesting to me. Oh, there we go. So what I want to say is, and Dr. Bindra was amazing in her description. Maybe you'll come be on one of our panels too at the Endometriosis Summit. But what I wanted to say is that this is your pelvis and this is your body, and it's a complex, difficult place to be in. And that endometriosis, here I'll show you on the previous slide, right? We can see that endometriosis, look how inflammatory this lesion is. It's getting its own blood supply. In a few years, this would have had its own nerve supply. And it really is an inflammatory lesion. You can't leave this in the body and expect to make do by having some stomach massage and a diet and doing vaginal steams. You know, you're never gonna, this really is what an endometrioma looks like, right? And with that endometrioma staying, it's also decreasing your egg quality. So I want to say that while endometriosis needs to be dealt with by expert and qualified endometriosis excision surgery, right? Because a birth control pill is not going to do anything for that inflammation or for, as Dr. Bindra mentioned, endometriosis makes its own hormones. Birth control pills aren't going to deal with that at all. That not all pain from endometriosis is only from endometriosis. I do believe if we were diagnosed earlier, then these pain patterns would not set up and the person would be significantly better off. That's why I love to support projects like the Endo What Nurses Initiative, because their goal is to really educate and get at diagnosis much, much earlier. And Heather can tell you all about that. She's amazing. She does a lot of work with that and with her own work. So I want to say that the entire pelvis is lined with muscles, bones, fascia, ligaments, and nerves. And this is just one photo from the membership site pelvicguru.com. And they did let me use their photos. So thank you so much, Pelvic Guru. They're Pelvic Guru 1 on Instagram. They run very fascinating feed there. But I wanted to show you that not everything inside is uterus and is ovaries. So therefore, treating everything either as we cut out or burn the disease. How about that? How about we'll leave the disease behind, but we'll shave the top off, or we take out an ovary or a uterus and that'll fix everything. We didn't do anything. First of all, for many, we didn't do anything about the disease, but we didn't do anything for any of these muscles. So what typically happens is, in an effort to protect you, the brain feels the pain from your endometriosis and it tells you your body to protect you and to create a spasm, right? So if you're reaching towards something hot, immediately you pull back, right? So that's sort of what's going on inside. And I know you, Dr. Shalippa, you have a dental background. Same thing happens. I started as a TMJ therapist. Same thing happens there. So the body is protecting you. And then in an effort to protect you, it feels pain from the spasm. So it spasms you more because pain causes spasm. Spasm causes pain. It goes on and on and on.
Yeah.
In many, if you're lucky, we cut out the disease. We do a qualified excision, perhaps by an eye care better doctor, and we get out the disease at its root. But no one's done anything for this spasticity, right? Nobody's done anything to lengthen and strengthen and have your pelvis groove and have your hips groove and make everything so nice. So some of your pelvic floor driven pain could remain even after surgery, and it doesn't mean you need more surgery. Some symptoms of that pelvic floor driven pain are pelvic pain, painful sex, particularly sex that's painful at penetration. And in one of my next slides, I'm going to show you why. Back pain, painful bowel movements, bladder pain, leg pain, difficulty emptying or holding urine, bloating. So that endobelly lots of times is because this complex is so tight, it's ballooning out your belly. And of course, stomach pain, constipation, diarrhea. And pretty much I could put up, I thought that was brilliant how you said, I'm putting up this blank slide because it could be anything. So I just, it's very important to understand that these muscles are there. And again, I want to show you that there's lots of muscles involved. And you can see, so it's a very common question, do I have sciatic endometriosis? So yes, a surgeon like Dr. Cernovo at the Center for Endometriosis Care has seen his fair share of sciatic endometriosis. I've been in the OR and watched sciatic endometriosis cases also, but they're not so common. And not everybody needs to immediately assume I have sciatic endometriosis, because I want to show you that any of spasticity, this is your sciatic nerve, and any spasticity in these muscles, particularly this muscle, which has some connection to the inside, is going to cause sciatic pain, right? So everybody's sort of like gripping their tushy a little bit, but it's actually coming from the inside. Look at the inside of your pelvic cavity, right? This is as if somebody was doing an exam. Where this finger is actually on the other side of this. So it's important to realize that endometriosis may sit here on the uterosacral ligaments, but all of these muscles are affected and all of these nerves are affected, right? So when you talk about, I'm constipated, oh, must have rectal endometriosis. And yes, you may have rectal endometriosis, but look at what could also be spasming. These are muscles that sit around your rectum. If these muscles are in spasm, then it's going to be very, very hard for the stool to exit. Now, remember I said painful sex could be at penetration. So you can look here. This is a muscle called transverse perineal muscle. And this muscle sits right at the opening of the vagina. So if it's hard to either get something in, or there's a burning there, or even for something to exit, put a tampon in, have your partner put something in, then it can very much be these muscles that are in spasm. What's very tricky is that these muscles are connected very much to the pudendal nerve, which is a nerve that sits on your tushy bone almost. And then also on there, this area of the body is very much connected to a groin nerve called the ilioinguinal nerve. So you see right now, everybody that's watching is like, who is this crazy American? She's speaking like another language. But my point is not that you're all going to go home and be pelvic PTs today, but it's that you understand this is a complex and it's a difficult thing to diagnose, and that we can't always be running into surgery. If you've had a good qualified excision, maybe it's time to think, is my pain generated for something else? So you know, now that you're thinking my pain could be generated by something else, well, what could you do at home? Like it's very, very hard to find a pelvic PT in India. If you are a pelvic PT in India, please reach out to me, because I have so many people every day that ask me. But I wanted to show you a couple things that you could do. This is something called the pelvic wand, right? And it's not so scary. We do prefer that pelvic wand training comes from a pelvic PT. If you can't get to one, that's my concern. So the pelvic wand comes from intimaterose.com, right? And what you can do is, if you get any part of the muscles that's spasmed, you can see how you can insert the wand and you can stretch the, oops, what happened here? And you could stretch those areas that are inside. And on the intimaterose.com website, and certainly the Endometriosis Summit Facebook page has also run a webinar on how to do this. We teach you that it's not about, we used to think that you mash the trigger point, you mash the trigger point, you mash the trigger. Well, I had patients actually end up in the hospital with that. I was once in a Facebook group and she told me she was using a candlestick to mash her trigger points. That is not what this is. This is a tool specifically designed for it that's silicone, right? And that also is very, very important. You're only pressing as deep as you would press against a tomato without the tomato breaking. Right? You shouldn't be any heavier than that. You find the point that's tight, you move your leg in and out, because you have to have movement. It's not about mashing. And then you find the next spot. It's not about bruising the tissue. And really, any PT that is teaching you to do trigger points and to bang against that tissue is not current with the times, right? So that's not going to help. So the other thing is, I wanted to show you, and for those of you that are at home, we're going to stand up and try it now. I'm going to stay in the share screen so that you can follow the diagram, right? So we're going to stand up and show it now, and you start at the right of your body. You start down low, and you're going to make a big clock, right? So if you're having stomach pain, you start and you make little clockwise circles, and then you go to the next part, right? I don't see anybody in my webinar playing with me.
I'm doing it in theory.
You're doing it in theory. Okay, fine. And you're going to come up, and then look, when you come up here, you're not above the rib cage. You're really below it, but you're really covering this area, and you're going straight across, because we remember ascending colon, transverse colon, descending colon. So we want to work on all these areas, drinking lots of fluids until you come all the way down, just like the picture. And that's really good for people that are constipated, particularly people that have had a lot of surgery and their bellies are tight. That's a great stomach massage. You could follow it with some heat on your belly. I do want to say, I'm sure our nutritionist is going to talk about why it's really important for anyone who may or may not have adhesions to be drinking water. But it is a great at home. These are two things you could do at home. But then the other thing that's super fantastic to do at home is we want you to breathe. Do I want you to go to a fancy spa and have nice music on and do diaphragmatic breathing? No, because you're never going to do that. You can find a cell phone or any kind of timer and set it anywhere between 2 to 5 minutes a day. Turn off all of your distractions and breathe. You can do it in sitting. You could do it laying down. You could do it in a recliner. You could do it on the train if we were allowed on trains again in the United States. but taking air in and taking air out is one of the things in research that's proven to decrease that tone and that spasticity in the pelvic floor. So those are things that you can do at home. And then I want to just remind everyone that there are lots of pain generators, and it's not always an organ. If one more person calls me and says, I'm going to take my ovary out, it hurts. Like, the possibility that you need an ovary removed is extremely low. Yes, it exists. If you have huge endometriomas, if you've had massive tubal ruptures, if you know, and a qualified specialist can help make that decision for you. But everybody that wakes up and they sit there and they go, I heard here, must be my ovary, must have to take that ovary out. I hear it like at least once a week, and at least once a week I take out this picture from pelvicguru.com and I point out that right in that area is the whole bundle of nerves, and you could have a lot of things that involve those nerves. Particularly a compression of those nerves, which is extremely common in people with endometriosis, and it's not viewable during endometriosis surgery. Right? So it has to be evaluated a whole different way. So just because you're pointing to your pelvis doesn't make it your ovaries or your uterus, right? So the same way I educate my orthopedic crowd on, just because somebody has back pain doesn't mean it's their spine, right? We know that endometriosis can cause tremendous back pain, right? But we want to tell the endometriosis crowd not to always assume that it's your organs, right? And the other thing to remember is that the bladder and inflammation within the bladder lining generates a lot of pain, particularly enough pain that we call it the evil twin of pelvic pain, right? And it has aftershocks, and usually front of leg pain is bladder, back of leg pain to me more often is endometriosis, and groin pain is a hernia. But none of these things say, hey, let's remove an organ, right? And so that's why it's truly important to work with a good surgeon who has a team, and the team needs to understand all this, or at least have a Facebook or an Instagram account where they can write me, because I get those questions all day long. Hey, I saw a patient, what about this? What about this? And to our practitioners out there, what I say is the most important thing is an open mind, because the person with endometriosis sometimes knows the most about their body. But for the patients out there, I want you to know, A, that you're not alone. B, that good care is out there and you have to know how to find it. And C, that not all pain, just because you have pelvic pain, does not always mean that it's endometriosis. And it also doesn't ignore, even if you have a good pelvic physical therapist, it could mean that it's endometriosis. It's a really difficult disease to work in. So this is the Endometriosis Summit, and we have a really great time at the Endometriosis Summit. We actually, it's hard for me to look back at it because we had the Endometriosis Summit, and then 3 days later, we all went into lockdown and quarantine, and I feel very lucky that we were able to be together with everybody there. Our goal is to be one voice in endometriosis to change the narrative. And we will host our first reproductive immunology conference online this October. And we will host the Endometriosis Summit online in March of 2021.
Awesome. Amazing. Dr. Sally, I can't thank you enough for the lovely presentation that you've made, and the simple steps that you have told were they're going to help a lot of women out there. I mean, seriously, I mean, no one has ever told me, I being a doctor myself, no one has ever told me about all these things, and I think I have to be very thankful to you. You know?
I find it amazing, like, I had already been trained as a pelvic physical therapist before somebody even mentioned the word endometriosis. That was only for people that had really bad cramps and infertility.
Absolutely.
Well, most people with cramps they don't realize they have bad cramps because we have normalized our pain. Our mothers had bad pain, our grandmothers had bad pain. And so whatever, this is like, you know, we don't realize that we have bad pain. So it goes both ways. You can't ignore endometriosis, but you can't ignore the role of the pelvic floor either.
Absolutely.
Really fascinating hearing her story, and the way it was amazing. She was describing all the
Presentation.
muscles and everything.
Absolutely.
That's
Well,
so.
you know, the minute I can get on a plane, I'm coming to see you. We're going to teach people to do it. We're going to teach them how to do an exam live. We're going to.
Yes, Sally, I want you
Absolutely.
to be here. I want
We
you.
would-
Yeah,
we would love to
Heather and I
see
are ready to come. We love to travel. You know, I'm sure.
Yeah,
But
as
it's-
soon as COVID is over, you are the first person.
Yes, absolutely. Heather and
That's
Sally
right.
have to be here.
Because I am recommending my surgical patients to do pelvic physio. I really want somebody to train my physiotherapist so that they can get the right kind of care post-therapy, post-surgery as well.
So I'm on my way. But the other thing I will say during COVID, the only thing that is an advantage to COVID is that we're all doing telehealth. So I've actually, Canada, who has terrible access to endometriosis care, and what I actually have been able to work with people in Canada on getting them like care over telehealth, you know. And so if there's any way we can help you in India that way, we would just, I have 2 in Australia also, we just would have to work it out.
Yes,
And
we'll do that.
you should check, I don't know, there's something called the Global Pelvic Health Alliance membership. It's run by Pelvic Guru. If they have someone listed in India, I don't know if they do.
We can surely check that.
We'll check that.
We
We'll
will.
do that.
Absolutely. Absolutely. So, Dr. Seema, my next question comes to you.
Yeah.
A lot of women with endometriosis have infertility. So, what percentage of women that you come across have infertility as a primary complaint? And another thing, and is it possible for such women to conceive naturally?
So, Shilpa, as Vimi has explained it so beautifully, followed by Shelley, and everything is clear. This disease is not confined to a particular space. It's not only about infertility. Sometimes people, they come to an infertility clinic, and as Vimi mentioned, they don't have any symptoms suggestive of endometriosis, and later on they're just being categorized as unexplained infertility. And when later on we are doing the laparoscopies or they are not responding to the treatment, we accidentally find that these girls, they were having endometriosis. So as per the literature, Figos and Ashray, nice, all these people, they keep counting things, as you have already told, that 176 million people,
Yes.
they are suffering from endometriosis. So it is something interlinked. People say 25 to 50% of infertile population is having endometriosis, and similarly 30 to 50% of endometriosis patients, they are infertile. And regarding their chances of conceiving naturally, it is very much there. The only drawback with this disease is these poor girls, they are not being diagnosed in time, as making the final diagnosis is an expensive affair. They have to go, you just have to put that scope, you have to call Vemi and get that thing diagnosed first. So that is the reason people are, they are being delayed in diagnosing, and that gives its impact on the fertility. You have to remember, this disease is an active ongoing disease. It's not a tumor, it's nothing, but whatever it is very painful, and it is not going to stop. If we are going to stop the disease, we are just preventing her to become fertile. So those 2 things, treatment of endometriosis and fertility, they don't go hand in hand. So that is the reason, once this girl, she's young, she's been diagnosed earlier, then it's easier for her to conceive naturally because the ovarian reserve is good. What happens, this endometriotic patches which are present inside the ovaries, they, whatever anti-inflammatory things, pro-inflammatory things they are secreting, that is leading to destruction of these follicles. That very endometrioma. It is suppressing all the natural follicles, so making your reproductive potential or ovarian reserve down day by day. So that is the reason for being infertile. So if her ovarian reserve is good, she's not having any endometrioma, she's having mild or moderate stage of disease, her number of years of infertility are not very much, there's no reason that these girls, they cannot conceive naturally. And sometimes when they are not being conceiving naturally, we are helping them with medicines like oral ovulations or sometimes intrauterine insemination. That is the thing. But there's no reason. These four things you have to keep in mind: your age. That is the most important thing, irrespective of the pathology in case of infertility. Second thing, number of years you have been infertile. Third thing, your ovarian reserve, and confounding variables, other cofactors associated with it, which are making at a stage of the disease. Obviously, that is very important. And even if you have got a very complex grade 3 or 4 disease, but it is not involving your ovaries and you are having good ovarian reserve, after getting surgery done by a good surgeon like Dr. Vemi Bindra Basu, you can conceive naturally. There's no point that you can't.
Absolutely.
I
That's
hope I answered everything.
absolutely, absolutely. Dr. Seema, that was very nice of you. And I think that will be a lot of women would have a hope coming up,
So
you
the
know.
really important message I want to give these girls, that they should seek the treatment.
Correct.
They should see the doctor, and they should be staged for the disease. Once they are diagnosed that they are a case of endometriosis, staging of disease is going to increase. And so the number of days and years are limited for you to become fertile and pregnant. So you should be having active treatment, and you should not just be very strict about that I'm going to conceive naturally only, otherwise I will not conceive. That kind of notion you should not be keeping. You should be very open, you should discuss everything, and counseling plays very important role. Your doctors, as you all were saying, that nobody could understand what you were going through. So first thing, that doctor has to understand what this girl is going through, and she has to help her.
Absolutely. So that's where my question to Heather comes. Heather, you have been, you know, a big name when it comes to advocating better treatment for people. So first and foremost, how did you get into it? You know, how was your journey about with endometriosis?
Very similar to everybody else with the disease, I think.
Sure.
You know, mine was a case where my symptoms, like many other people with endo, they started well before my first period. So I didn't even know then that anything was wrong. But then after I had my first period, and then in the years ensuing, I thought it was completely fine and normal to miss school and social functions, you know, have to call out of work. I thought this was all very normal because nobody ever said to me, oh, guess what? Your periods shouldn't be crippling. We never talked about it.
Absolutely.
You know, there's not only is there a stigma around painful menstruation, but we make light of it. You know, it's, oh, Aunt Flo, or, you know, oh, my cramps are so bad, or killer cramps. So I really never gave it much thought. I just kind of, you know, popped a couple Excedrin and went about my business. But it got much worse as I got older. I'm a little different in that I was diagnosed pretty quickly. It only took me about 5 years to get a diagnosis. And I was very, very lucky because after I finally had kind of thrown in the towel and said, I can't live like this, because then the symptoms had really started to increase. It wasn't just painful periods. It was crippling bowel pain. It was bladder problems. It was lower leg and back pain. It was constant, and it really started to take over my life. Painful sex. Couldn't sit. I couldn't cross my legs. It was, you know, all of these increasing symptoms that finally led me to go see a wonderful GYN who immediately on the spot in his office said, yeah, I think you have endometriosis. Now, remember, this is in 1988. So we didn't have the internet. I couldn't text Sally. We didn't have a network. I was alone, basically. And he said, yeah, you know what? I have to do surgery for you. So that was a hip to hip surgery. So, I came out of anesthesia, and it was my first major surgery ever. I was still only in my late teens. I had no idea what to expect. And he said, yeah, you got stage 4 endometriosis. I'm going to give you a couple birth control pills. You're going to take them all the time. It's going to fix all your symptoms. Oh, by the way, you're never going to have kids. And I thought, wow, okay, so this is, all right, I'm just starting out in my life, and this is what you're laying on me. And I didn't know any better. I didn't know at 19 or 18 years old, like, okay, what is endometriosis? What impact is it going to have on my life? How am I going to navigate inside this space? And although he was very good to me in terms of, yes, believing my pain, yes, taking me in for surgery, yes, giving me a diagnosis, that was really the spiral. That was the start of the spiral, because then I started seeing other gynecologists and fertility specialists and reproductive endocrinologists. And that, over those ensuing years, that was really when I realized that I had no agency over my own body at that point. I would go to the gynecologist. I would tell the same story. My symptoms are killing me. I'm not getting any relief. I'm worried about my fertility. Meanwhile, I'm trying to get married, start out in my career, have a life, all of these things. And instead of really any of them ever sitting down and saying, okay, we have options, here they are. They told me what to do. All right, we're going to do another surgery. We're going to put you on Lupron. We're going to put you on this pill. You're going to take Clomid. You're going to do this. And pretty early on in the process, I became very, very outraged, which is probably a really good thing, because here I am today, right? And I thought, if they don't even understand the disease, how are they supposed to explain it to somebody else? And that was really where my work started. I didn't envision myself becoming some sort of endometriosis mouthpiece. That wasn't on my vision board. I was working in Manhattan in investment banking, but I am a writer, and that has always been my thing. And I started doing writing for advocacy purposes, and I started connecting pen pals, because again, there was no internet. I was connecting through the Endo Association with other people who understood. And I finally started to catch on that this is an epidemic. This is a problem. And if we're not going to fix it, nobody is. And that was really where my full-time focus began. And, in my very early 20s, started focusing on endometriosis advocacy and education. I was hoofing down to medical libraries at universities. I was printing off, now what we can get off PubMed. I was pulling out of medical journals. Started meeting with physicians and beginning to tell my story. But in all of that space, I was still struggling with terrible pain and infertility. I was still having multiple surgeries with no resolve. I was still infertile. I had kind of given up hope. And lo and behold, here comes the internet. We're all going to jump on board now. We're going to find, like-minded souls out there in endo. And I came across Nancy Peterson. Right, who doesn't know Nancy? And she was in a board, an endometriosis board that I had been hired to moderate for America Online, if anybody remembers AOL health boards back in the day. And she said, listen, I'm in this little hospital out in rural Oregon. There's this great doctor here. He does something called excision. And I said, oh, okay, yeah, I haven't heard of that. I only know vaporization. I've only had vaporization and ablation. Yeah, let me get in touch with him. So I fired off my records to him. And As it turned out, it was David Redwine, who needs no introduction in our community. And he said, he sent me back this letter, and he said, I think you need this, 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 and this done. You've got bowel endometriosis, you've got suspicious for diaphragmatic endometriosis, you've got bladder endometriosis, et cetera, et cetera. He did not do my surgery because, in my mind at the time, like get on a plane, fly to Oregon. No. But I did get on a plane and I did fly to Atlanta to the man who saved my life, who founded our center, Dr. Bob Albee. And Dr. Albee worked on me for 6 hours, and I woke up in the recovery room. And yes, I had a lot of pain, but it was a new pain. It wasn't the unrelenting, constant agony that never went away. It was truly post-operative pain. And he said to me, I think you're going to be all right. I think you have adenomyosis, but we've kept your uterus. I think things will be okay. Let's revisit the adenomyosis, because I had really wanted to keep my uterus, even though I couldn't have a kid. He said, we'll revisit this in a year or so. I got pregnant 4 weeks later. My son just turned 22. So, if you're out there and you're having multiple surgeries and they're putting you on these drugs that were never intended to treat the disease, and they're sending you to fertility specialists who don't want to treat the disease, but they just want to treat the symptoms, then I implore you, please, please find a specialist. Go see Dr. Vimy. Go see the Center for Endometriosis Care. Go see any of the excision specialists who focus on this disease out there, because you don't have to suffer. You do have agency over your own body and your own treatments, and you do have a right to accept a very high standard of care. And that really has been, my focus for the last 29 or 30 years, is making sure that somehow, some way, somebody else doesn't have to go through all of this. I shouldn't have spent the entirety of my 20s doubled over. I shouldn't have missed out on my honeymoon. My husband should not be, caretaking his 20-something-year-old wife. I mean, that's just not what it's about. So I want to really make sure that people are connecting with the right care and the right adjuncts after excision surgery. That it's, as Iris Orbuck says, it's not the path to multiple surgeries. It should be 1 or 2 surgeries done right. Because my disease was so ineffectually treated for so many years through so many surgeries, I will never be perfect. I've had a hysterectomy at an early age, so there's ramifications of that. I've had multiple surgeries, so there's ramifications of that. I've had drug therapies that now, even still, we wonder what's the impact of that. So my goal, and the goal of all of us who are active advocates and educators on the disease, is really to connect to the right care early on. But we also have to change the medical institution. There's something very, very wrong with an industry that does everything about us without us. And that's where things like the Endo Summit, initiatives like Endo What, some of the really good organizations out there, that's where we all come together and we collaborate. Dr. Sinervo, who I've had the privilege of working for 15 years, every single day he shows up in his OR to fix the work that somebody else screwed up, because he's so committed to changing lives. If they had gotten to him and the medical oversight bodies had sent that patient to the right care early on, maybe we could all retire. So that's where I come in.
Perfect. I mean, a story that probably most of us would relate to. You know?
It's not unusual at all.
It's not. But tell me something, Heather. How should a woman decide if the doctor is right for her? What are the red flags that a woman should see, a person should see, to see when to seek a second opinion? There's something particular.
Well, that's the problem. Sally will tell you, Dr. Sorrell will tell you, I say all the time, the internet is the best and worst thing to ever happen to this disease. The best thing because it really has paved the way for international collaboration. I mean, 10 years ago, I don't know that we would have this event, right? So in that regard, it's fantastic. On the other hand, it's really a double-edged sword because anybody can say, I'm an endometriosis specialist. Anybody can hang up a shingle and say, this is my disease, this is what I do. So the way that you really have to interview, and you do have to interview, is really go in as an educated patient and just really ask those tough questions. And I know that's very difficult to do because of the power balance. There is a structure. When we become a patient, inherently we start to go, oh, okay, yeah, well, the doctor said. I myself am guilty of that. But that's wrong. And we need to kind of stand up against that and really ask those tough questions. Okay, what do you specialize in? How much of your practice is dedicated to endometriosis? How do you treat endometriosis? Do you treat it surgically, medically, or both? And if you treat it medically, why and how? And if you treat it surgically, are you removing, are you cutting out all of the disease from all locations? Are you sending that tissue to pathology so I know what was found? And to that end, are you going to treat all the disease in one encounter? In other words, if I show up and I have bowel endometriosis and I need a bowel resection, which I did, is my surgeon going to say, I didn't have anybody to do the resection, so you'll have to come back in 6 weeks? Or are you going to have a multidisciplinary team in place that says, okay, the colorectal is here, the cardiothoracic is here, the urology surgeon is here. You can get this all done in this multidisciplinary setting. So I think that's very important, is to find out what their approach is and how they do it. But also I think you need to ask about outcomes. And there's a lot of pressure on kind of that publish or perish mentality. And people seem to think that if your surgeon hasn't published 55,000 things on endometriosis, then they're no good. And my answer to that is, publishing is a secondary pursuit when you're in the OR every day, changing lives and saving lives. But most of the centers will have their own outcomes, and you can ask about that. And they should be very happy to share those outcomes with you, whether it be, overall 10% recurrence or whatever the case may be. You can ask about that. Make sure you're going to be treated as a partner in your own care. Do you have autonomy to make your own decisions? Are you the ultimate decider of what drug you're going to take, what surgery you're going to have, and why? And I think that there's a lot of credit to the endo community when they are the ones that now can funnel everybody to the right surgeons. Nobody's perfect. Nobody's going to have a 100% success rate. Nobody's going to have 100% perfect reviews. So maybe Dr. Vimy. But there's something to be said for overwhelming, compassion. You hear from the patients, he or she is compassionate. They're dedicated to my care. No, they didn't say they'd cure me, and they care that I have recurring symptoms. There's a lot of chatter out on the boards and on the groups where you can talk to others and find out. To me, it's way more important what a patient thinks about their surgeon in terms of how they feel and how their bedside is, than 95 articles in JMIG. I don't care what you've published. I want to know what you're going to do for me. So ask others. And that's where the I Care Better vetting system also comes in. I don't know that we're going to have time to talk much about that today, but there are people out there fighting every single day for this disease. Dr. Sorrell and I are two of them. There are a lot more behind us, and there are many who came before us. We are working very, very hard to try to change how patients are connected to care, to ensure that that care is legitimate and not just some, politically influential person who was paraded around a gynecology congress. And there's different mechanisms that are in place that we're working on to ensure that that happens, because frankly, in the last century, nobody else has done it, so it's our turn.
True. True. I completely agree with you. Completely on with you. So Gayatri, I wanted to know from you, Gayatri, how does diet affect endometriosis? And if it does, what are the best foods to have, and what are some things which you should completely avoid?
Well, hi everyone there. Good evening. When we speak about diet, yes, diet definitely plays a significant role in endometriosis. We'll all definitely agree with the fact that during ancient days, food was considered a medicine. And every ingredient that we use in our daily cooking has a medicinal property. There's no doubt about it. Here in endometriosis, we definitely, yes, we ask patients to go on foods which are rich in anti-inflammatory properties, which helps them to, reduce this pain and other symptoms which are associated with endometriosis, like bloating. Constipation is another very common problem, cramping, heavy menstrual flow and all that. So once patients have a clear picture of what to eat and what not, then they kind of get rid of the mental stress as well. And they are very clear on how to go about in their meal planning, which is very important to carry on with the day-to-day, life. So this also helps to improve the efficiency of, the uterus, improve the ovarian efficiency, and helps to reduce this extra circulating estrogen, and improves, enhances fertility as well. So when we come to foods, what we need to include for endometriosis, it's an interesting list. First, so let me go with the slide. So this is how an endometriosis diet typically should look like, where it will have adequate amount of fresh fruits and vegetables included in your plate, with whole grains, with a certain amount of fatty fish which are rich in omega-3 fatty acids, and eggs, and for vegetarians they can go for nuts and seeds, and tofus, soyas and stuff like that, with a restricted amount of dairy products as well, and healthy fats.
Okay. All right. Is there some restriction on the diet? What's the kind of a diet which the patient should not be having?
Yeah, so I would like to continue. When I speak about fresh fruits and vegetables, they have to give importance more to organic source, because most of these fruits and vegetables, they are loaded with pesticides and inorganic fertilizers, which actually increases the toxicity, and causes a toll on the hormonal imbalance. So not only that, fruits and vegetables, as we all know, are rich in vitamins and minerals, and this vitamins helps to bind the circulating estrogen and helps to excrete it as well. And the fiber also plays a very significant role in women suffering with endometriosis, and they are also rich in flavonoids, which have anti-inflammatory and antioxidant properties. So it is very important that they fill their plate with brightly colored vegetables, like dark green leafy vegetables, or your like kale, spinach, amaranthus, name it, anything, methi, also go with the cruciferous vegetables, like broccoli, cauliflower, Brussels sprouts, kale, and stuff like that. So it is very important that they have at least 4 to 5 servings of fresh fruits and vegetables which are organically grown. And then coming to omega-3 fatty acids, this is very important for women suffering from endometriosis, because it helps to reduce inflammation and it helps to increase the ovarian efficiency. For non-veg people can opt for fish like tuna, then salmon, mackerel. Now vegetarians can either go for omega-3 supplements, or they can go for natural food like nuts and seeds, like your hemp seeds, flax seeds, chia seeds, sunflower seeds, pumpkin seeds, all these seeds, which are a good source of omega-3, along with soya, tofu, and beans and legumes as well. And not only this, incorporating healthy fats is very important. Again, like, fatty fish and stuff like that, and try to cut down on trans fat and your labels which reads as hydrogenated vegetable oil. So try to cut down on all these stuff, and also include lean meat, than red meat, because again, red meat increases inflammation and also increases your serum creatinine level, and it causes toxicity. And red meat, when I speak of red meat, when I speak in general about animal products, it just as how we offer organic fruits and vegetables, it is preferable to go for organic, sustainable grass-fed, poultry, because again, there are a lot of toxins which are, involved in it, like PCBs and dioxins, so which will again cause, hormonal imbalance, especially with women suffering from endometriosis. So they can go for sustainable grass-fed organic meat, or they can opt for plant-based meat substitutes, which are very much available these days, which are environment friendly, and they are also, give the exact taste like meat, and they are plant-based. So these are available in Amazon as well, so they can opt for these, when we speak about meat. And then coming to dairy products, you have to go for low fat dairy products, because of the, we don't want too much of saturated fat, content in your meal, because saturated fat also increases the circulating estrogen, and it again takes a toll on your weight. So watching your weight is definitely very important in endometriosis. So low fat dairy products, again going for organic dairy products, or if you are okay, you can turn to be a vegan. So vegan diet is also, beneficial, where we completely, remove all your animal based products, and we can go for substitutes like soya milk, or almond milk, or hemp milk, and stuff like that, so that we don't end up in any nutrition deficiency. And then coming to whole grains, so it is very important that they also take good amount of whole grains, like your buckwheat, or brown rice, or millets, or quinoa, so that you have enough fiber. Not only they are rich in soluble fiber, but also zinc, potassium, manganese, folic acid and stuff. So definitely this will also be loaded with fiber, and they are also low glycemic load foods. So beans and legumes, and lean meat, and with a limited amount of dairy products, which are with very less amount of fat, and going organic would be the best option for an endometriotic patient. Am I clear, Dr.
Absolutely.
Krishna?
Absolutely. Absolutely. I mean, you were like pretty
Yeah.
much clear. Yeah.
And yeah, one second. So when you ask me what foods to avoid, see, there are list of foods where they need to take care, and they can, once they master this art, then they can kind of record it and validate it, because again, everything is differs from patient to patient, as Dr. Vimi says, because what is tolerable for one may not be suitable for the other. So they have to kind of go on a trial and error basis and see what suits them best. First and foremost, what they need to avoid very much and very strictly is, they have to cut down on all sweets and sugars. Your sweetened drinks, juices, artificial juices, colas, fizzy drinks, any kind of white sugar, or they can go for jaggery, or palm candies, or flavored yogurt, something like that, if they have a craving for sugar. And because sugar definitely increases inflammation, and it kind of produces cytokines, which are inflammatory messengers in the body. So we definitely need to cut down on all kinds of sugars and sweets, and go for palm candy or jaggery as a substitute. and avoid anything that is greasy, sticky, processed, which has additives and which are where it contains more of trans fat, where your label reads anything as hydrogenated, vegetable oil. So first and foremost, when they go for their groceries, it is, it may be silly, but then they need to take time to read the label and see what is exactly mentioned in it, so that they're clear, yes, whether this is going to suit me or not. So just give that little bit of time for your health and pick the right stuff so that you are comfortable during your menstrual cycle. And as I told you, avoid processed fat. They are full of additives and they are highly rich in saturated fat. They also take a toll on your LDL level, and they cause fatty liver. So, they increase the circulating estrogen in the body, so which is very difficult again. So, trying to cut down on processed food is important, and restrict your alcohol and caffeine content. So just going with just one glass of caffeine with about 200 milligrams per day would be sufficient enough, because again, caffeine, it kind of, plays a role in the fertility aspect, and also it, decreases your ovarian efficiency. So caffeine restriction with alcohol restriction is also important. And you can restrict dairy products, or you can, as I told you can turn to be a vegan with, where you can remove your dairy and go for, other plant-based milk and yogurt source. Right, you have some, I can just share a slide where we ask them to, sometimes go on an elimination diet. So elimination diet will actually have two phases. One is, the first phase is actually you eliminate it, and after a period of, 15 or 1 month, then you slowly reintroduce and see what kind of suits you, and what is tolerable for you. So if you take dairy products, here I have mentioned, like, you can, kind of get rid of cow's milk and go for almond or soy milk, or lactose-free milk and yogurt, lactose-free yogurt. And, you can avoid margarine and go for dairy-free margarine, or, these kind of list will definitely help them. And this will be available in our website, so there is no they don't need to take tension. This is going to be available, so they can always refer at any point through our website. So again, gluten again plays another role here, because of the severe pain, and this is purely associated with the digestive system, where there's a lot of belching, abdominal cramp, indigestion, constipation, and all those stuff. So they are not able to digest this gluten, most of them. Some people are able to, but in severe cases, yes, they're not able to tolerate gluten. So it is better to go on a gluten-free diet as well. So I have quoted the list of, gluten-free foods here, which they can opt for. And again, sugars to be avoided on elimination diet. All your fizzy drinks, your cakes, cookies, pastries, and all that, because all these has yeast as well. Your bread, pastas, your pav, everything, because yeast is also, one of the contributing factor. Wheat, rye, oats, barley, yeast, malt beverages, all these have to be excluded on a severe endometriosis patient.
Okay.
Yeah.
Okay. Sounds fine. I mean, I'm sure there's a complete list. You have to probably what I feel is elimination is the key. That's what you'll have.
Yes. So they have to actually self-assess. They have to go on a trial and error basis.
Absolutely.
Yes.
Sorry. Continue, please.
Yeah, they have to see what suits them the best, and so that they get a clear picture, and that is why they have to record it and validate it, so that they don't forget. So they are more disciplined in their approach. So once they're comfortable with their meal plan, another thing is diet should be loaded with magnesium as well, because during menstrual cycle there is a loss of magnesium, and magnesium helps to reduce cramping, and it kind of relieves the muscles of the uterus. So thus it reduces pain. So you have to pack your diet which is loaded with magnesium rich foods like nuts and seeds, and again tofu, and a lean protein, fish, palak, that is spinach, okra, and potatoes with skin, and they can take it to a certain extent. So magnesium definitely is important to be included in the diet. And iron-rich foods again is very important because the loss of iron during this menstrual cycle, and they can go for dates, figs, walnuts, and they can even go for broccoli soup, which are rich in folate, and spinach soup. Mm, so they can just try to make it more interesting so that they are loading their diet with iron as well. Am I
Great.
clear?
Absolutely, absolutely. So the takeaway point for everyone is that a food diary is something that will help. If you start noting down what's suiting you and what's not, that's going to be helpful.
Yes,
Yeah,
exactly. So they have to validate it. And
absolutely.
Can I ask a question? Is that allowed?
Absolutely, Sally. Please.
So I do a lot of work in my practice with diet. I actually have a background in nutrition. So my question is, I hear you recommending nuts and seeds and tofu. Nuts fine, but the estrogenic nature of the seeds and of the tofu, we don't do that here in the United States. We try to remove almost all soy from the diet. Do you
yes,
recommend that? Is that a regional recommendation because of the vegetarian diet in India, or you really think that the estrogenic load of seeds and tofu is not that much?
no. So what for your question, what I would say is, Dr. Sally, certain foods they do have phytoestrogens in them, and tofu and soya products do come under that list. But in severe cases of endometriosis, where the lady is really not able to tolerate it, they can exclude. But where, as I told you, it differs from person to person. Again, so, I may be able to tolerate soy milk, or soy products, but the other person may not be able to. So they have to then, if it is not suiting them, yes, they have to restrict on flax seeds and nuts and soy products, because they do have phytoestrogenic properties in them. So I do understand, and if it is very severe, then it depends on what suits them and what they need to exclude. So it depends on the severity of the condition, the pain or the cramps.
Good, thank you.
Welcome.
That was quite informative. So, Sally, you have your pooch there, is it? So sweet. Okay, so when we find, we know what endometriosis is, what it can do to you. How cute is that, Sally? That's so sweet.
Dr. Shilpa,
Yes.
yeah, sorry to interrupt. See, I have an AV which I want to share here,
Uh-huh.
which shows foods which have anti-inflammatory properties. So can I go ahead?
Sure, please.
Yeah. Are you able to view it?
No.
Mhm. Okay, just give me a moment. I'll revert back.
Fine. I'll carry on with Vimi.
Sure.
So Vimi, can you just give me some treatment options once you're diagnosed with endometriosis? What are the treatment options which are available?
Okay. Shilpa, before I go on to this thing, I would just like to mention here two names which Heather mentioned. One is Dr. David Redvine. He has done a lot of research on endometriosis and gave us a theory of mulariosis, which could contradict the Sampson's theory, which people believed for ages that retrograde menstruation is the cause. So we have learned a lot from his scientific research and the work he has done, and he's the pioneer of excision surgeries. And another name which comes with endometriosis is Nancy. She
Absolutely.
has done enormous work, and really we as doctors have learned a lot from her group. Not only patients are learning, I think all over the world doctors are learning a lot from her group. The amount of work they are doing is tremendous. And one more thing, as Sally mentioned, that our grandmother suffered and everybody has suffered, and they are made them believe that the pain is normal. So this is a conditioned reflex for women. Basically, mostly they were always told that painful periods are normal, mild pain is okay, you get married, you get children, your pain will go away. So that has been there for ages, and this was the main reason when endometriosis diagnosis was delayed.
True.
Now, when we talk about diagnosis, first, as I already told you, talking to the patient, proper history. Examination, the bimanual examination helps us a lot. We can get a lot of information about the rectovaginal nodules, uterosacral pulling, the rectal examination. It gives us a lot of information. The big endometriomas can be detected on a clinical examination, and then comes the role of good ultrasound. Now, your sonologist should be so good to pick up the lesions. We have people who can really pick up even the peritoneal lesions or the adhesions between the bowels. They can describe those bands of adhesion, and that kind of sonologist should be there for you to give a correct diagnosis. Sometimes you will not find anything on the ultrasound, but patient will have endometriosis on laparoscopy. So even if you do higher investigations like MRI or CT scan or any investigation, you might miss on the diagnosis if you don't correlate with their clinical symptoms and you don't suspect endometriosis. Like we say, you have to be ectopic minded to diagnose ectopic. So you have to be endo minded to diagnose endometriosis, correct?
Absolutely.
Yes.
So you have to think about that, and peritoneal endometriosis might be missed in most of the cases. And we have patients who have severe pain, they can't even walk, and they have only peritoneal endometriosis, and their ovaries, uterus, everything looks fine, absolutely fine.
I think that's part of the problem too in not seeing a specialist, is because you're going to have people who will rely on imaging studies that are negative, even if the case is a stage
Yes.
4.
And then they are told that it's normal.
Missed. Exactly.
Nothing is there on your ultrasound, and they are being put
Absolutely.
on Lupron and other medications for years together.
Exactly.
And the disease keeps on growing because it's a progressive disease.
Right. Right.
Now, when you ask me the diagnosis, the gold standard is laparoscopy and histopathological correlation and nothing else. And on laparoscopy, gynecologists, I know pelvis is our domain, but they need to look out. They need to see everywhere. Not only the pelvis, they need to inspect the bowel properly. They should see under the diaphragm, liver, everywhere they should see nicely so that they don't miss on any of the endometriotic lesions, and they can remove it if required. Now, diagnosis, I would like to mention here, Olympus also has a narrow band imaging in which they can pick up some of the lesions with microvasculature. So early lesions can be picked up with the narrow band imaging. So that can also be tried if you think that you can't identify endometriotic lesions. Mm-hmm. Now comes the role of surgery. So when we talk about, one second, I'm just sharing the slides. So there are two kinds of treatment people keep hearing about is, one is, one more thing I would like to mention, the role of CA125. The CA125 is not diagnostic. It is just a simple blood test, and it can be elevated if you have very painful or inflammatory lesions. So if you CA125 is high and you have been diagnosed with endometriosis, don't get scared because these lesions are not cancerous. So most of the time people come to us fearing that CA125 is so high, I might be having cancer. So that's not the fact. CA125 is just a marker and it's not diagnostic of endometriosis. Now, ablation and excision, there are two things which I would like to explain. So ablation, as already Heather has mentioned, she underwent ablation, and we can use various energy sources for that, monopolar, plasma jet, we have lasers, we have CO2 laser. So many things are there for ablating the lesion. So ablation is just burning the surface and the roots are left, as you can see in this simple diagram where we are burning the tissue, but burning the plant, but the roots are there. So it keeps growing. We do not remove the underlying disease, which we can't see from outside. Now, if we come to the excision, now excision is scooping it out. We completely scoop it out and we remove the lesion. And if required, we restore the functionality of the tissue. Now here comes the role of multi-specialty, which already Heather and Sally have mentioned. If I need a urologist, if I think ureters are involved or kidneys are involved, I might need a help of urologist. I might be doing the surgery, but I keep them with me so that they can guide me when I proceed. I might need a colorectal surgeon. And if it involves other places, yes, other specialties may be involved if it is under the diaphragm. So ablation and excision has to be understood very well. Ablation also can cause damage to the underlying tissues, whereas in excision, we separate the tissue nicely and we remove only the endometriotic tissue. And that's very, very important, where you remove the complete tissue with the roots when the progression of the disease can be stopped. I'm not saying that if you do excision, disease will not come back. It is a recurrent disease. It can come back. But yes, a good excision gives you a very good disease-free interval and good quality of life. So this is what I want to stress upon, that people should know about the difference between the two kinds of surgery, what we do. So the surgical treatment is the only option I can give as a laparoscopic surgeon. And
that's true with me. I mean, see, gold standard wise, laparoscopic, an excision surgery is the best. And probably most of us know it. But then why don't most of the gynecologists advise it?
Yeah, it's a difficult question to answer. Yes, somebody would like to answer this?
It takes years and years and years to learn all of the nuances and have surgical prowess in excising the disease. I don't care if you use a robot or fluorescent technologies. If you cannot excise, no tool is going to make you an excisionist. It takes thousands and thousands of cases to become an expert. If you are not dedicated to endometriosis care, that's something that probably would not interest you in terms of a professional perspective. So people either don't know it exists, can't do it themselves, and therefore don't want to recommend it, or have other nefarious reasons for not wanting to refer out. You know, as I always say, when in doubt, refer them out.
Yeah, there are two more things.
They can do it, they just don't recommend it.
Dr. Bindra, is the pharma stronghold in India just as bad as it is in the United States?
Sorry, Sally, I didn't get your question.
Is the stronghold of pharmaceuticals just as bad in India as it is in the United States?
Absolutely, yes.
It is.
Absolutely.
Really?
Yes.
That's surprising.
No doubt about it. So first line of therapy, most of the patients who come to us, they have already taken Leupride and other stuff.
That's the first thing
they
that
have
anyone
tried everything, and then they come for the surgery. Even patients don't want to undergo surgery. They are afraid
to not recommended in the first place.
Yes. If the first doctor tells them that surgery is the first option, then definitely they'll have in their mindset different. Also, if we talk about why gynecologists don't recommend excision or surgery as the first thing, endometriosis should be a subspecialty. And it is not given that much importance in the medical school with the busy obstetric practice and other gynecological, this thing is there. So it should come up as a subspecialty where the separate training is there. And it should be a long-term training where the mentors teach them the excision surgeries. Then only it will take place. Otherwise, as a general obstetrician and gynecologist, one is you have lack of time. Each surgery might take 4, 5, 6 hours together, and they don't have time. And when they are busy practitioner, ablation is easier. They ablate and come out.
Correct.
So these are the things which take a backstage, and when comes to the recommendation. Also, the teaching and training part should be strong enough when we can raise excisionists, and then obviously we can serve them.
True. And a lot of times hysterectomy is suggested. Is it a cure for endometriosis? I contradict, but is it? I mean, you need to, tell me.
So already the first line I said is it is outside the uterus. So if you remove the uterus, how do you get rid of endometriosis? You tell me.
Correct.
So it is not a disease of the uterus. Adenomyosis is a disease of the uterus where hysterectomy works, but endometriosis is not a disease of the uterus. So removing the ovaries and removing the uterus does not help you. It's the endometriotic implants which needs to be removed. So pregnancy cures endometriosis, hysterectomy cures endometriosis. These are all myths which has to be removed. It is not. So pregnancy does not cure endometriosis, it may worsen it. And hysterectomy does not cure endometriosis. We get so many postmenopausal women, surgical menopause, and we get endometriosis and we are excising them.
True. That's right. Heather, can you elaborate on how should a woman prepare for a surgery and what should she expect out of it? Post surgically, what does she go through?
Definitely. We talked a little bit about how to choose your surgeon, and hopefully you've made the right choice. So now you're having your surgery. There's a lot of ways to prepare both preoperatively and to kind of deal on the back end as well, postoperatively. We in our center, we tell patients, this is an investment in your health. So everything that you do now and that you do after in the post-op phase is really important and can have an impact on your recovery and maybe even your outcome. Proper diet, exercise, stress management, these things are really important. This is the time when you should really be investing in yourself. Make sure you're eating right, you're getting enough sleep. Unfortunately, in the days of COVID, we have also added a requirement that you must quarantine before surgery. So that's a new one. We've grown with the times there. But again, preparing yourself through proper hydration, approaching your diet from a non-inflammatory perspective, no sodas, reduce caffeine if you can, make sure you're eating lean proteins, whatever a healthy diet looks like to you that cuts down on the inflammation, whether that's vegetarian or whether you incorporate lean red meats once in a blue moon. Whatever that looks like to you, the goal is to reduce inflammation and eat properly. Light exercise. I know if you're in pain, that's the last thing that you want to do. But if you can swim or you can do, light weight bearing or something that keeps you active, that keeps you moving, whatever, again, that looks like to you, we do definitely encourage that. As far as things like supplements and herbs, you'd really have to talk about things like that with your surgeon, because before surgery, there's some things you can't have, that your surgeon will want you to come off of, whether it increases bleeding or impairs clotting or something like that. But those are things that you can talk to your surgeon about. And I do think that you need to prepare your mind as well. Maybe that means that you're going to a couple therapy sessions just to get in the right headspace, because think about it. By the time most people are going into excision surgery, we've already had multiple other surgeries that failed. So there's often a sense of distrust or mistrust. You're afraid to hope against hope that, okay, this time it's going to be the one, this time it's going to work. And I do think that, talking to a trusted therapist can really help you reframe it and give you some important coping tools, which can also probably help you on the back end as well. I think after surgery, from a practical perspective, if you're traveling for care, as so many of us have to do, packing that hospital bag correctly, making sure you have all your meds and your high-waisted pants, comfortable clothes and things like that. From a practical perspective, you want to make sure that you're doing that. But I also think realistic expectations are critical. And I cannot stress that enough. After excision surgery, you're going to have pain, and it may be severe, and it may last upwards of 3 months or more, depending on what you had done. So I think it's very important that people are having realistic conversations with their surgeon, and that they're understanding this is a long-term process. You are not going to wake up out of surgery, come out of ambulatory care, go back to your house or your hotel, and the next day you're going to be at the mall shopping, feeling wonderful. This is a process. Yes, you're going to have the post-op recovery, probably takes a couple of weeks till you're able to go back to work or school or whatever, go back to the gym, go back to working out, whatever that looks like for you. But you're still healing. And the healing process can take quite some time. Your first period after excision can be excruciating because that's a raw surface, for lack of a better term. So I do think that being realistic about the outcome for, in terms of healing, what that's going to look like. And if you feel great before, 4, 6, 12 weeks, that's fantastic. But being realistic is really important. We've had patients that will contact us 2 weeks out of surgery and I don't feel any better. Okay, well, we want to work with you. We want to make sure that you're understanding what are your limitations right now and why are we having you limit X, Y, and Z so that you can do it down the road. We want patients to really understand this is a process, this is an investment. And what happens 6, 8, 10, a year later, months later, now you have pain again. Okay, so now we need to really deal with that. And these are all realistic things. These are things that can happen. If you have pain, what do? Oh my God, I had this surgery. I don't feel any better. What happens? Okay, so then now we need to investigate what are the secondary pain generators. Are you going to physical therapy like we encouraged you to do? Are you seeking pain management? Are you following your post-op protocols? Is there something else going on? Do you have adenomyosis? Do you have fibroids? Do you have PCOS? Do you have some other condition or a secondary pain generator that is contributing to your pain? Because not everything is endometriosis. And I know that better than anybody because I'll be the first one to say, oh, they didn't get all my endo, so it still hurts. Well, even after they got all my endo, it still hurt because I had adenomyosis. So you need to really, yes, choose your surgeon with care. Make sure you're getting a subspecialist who only focuses on endometriosis. But realistic expectations are important too. And your surgeon should be working with you on all of those things so that you're not surprised when you have your first period. Or that, 6 months down the road, you're still tired or fatigued or exhausted. You're still going to bed early in the night. These are all things that should be discussed at the time of booking your care, because there's nothing worse than having unrealistic expectations and suddenly, you're caught out there because now, oh my God, I'm tired. I can't eat right. I still have pain. My periods are killing me. There's a reason for all of these things. You need to know what some of them may be.
Well, Dr. Shilpa, in this context, I would like to present the AV, which shows the foods which have anti-inflammatory properties, so the patients get a clear idea.
Not visible.
Is it not visible?
Gayatri, the slide is not
The
visible.
folder is visible only.
It's visible for me.
Yeah,
The presentation is not visible, Gayatri.
just put the optimize button on, then you can.
Let me just check. Give me a moment. Is it visible now?
No,
ma'am.
It's still the folder that's visible.
Ma'am, what you can do, open your video or whatever the PPT, minimize it on your desktop, and then use the function share screen, and then select that particular PPT or the video.
Okay, okay, fine. Is it visible now?
Yes, it is.
You're able to view it, right?
Yeah.
Okay. This is again going to be available in a website, so they can refer it anytime they want.
Okay. The audience can keep putting in their questions. If we are not able to answer immediately, we would put it in the chat box. So don't worry about that.
Extra virgin olive oil. They can also go for cold pressed oil, which are the best source of omega-3 fatty acids as well, and they are free of toxins. They don't undergo any heating process, so they're anti-carcinogenic. Dried berries, fresh berries, good source of magnesium as well. They can also opt for magnesium supplement based on your doctor's recommendation. It can be magnesium powders or sprays, or you also get these Epsom salts, which are magnesium sulfate compounds. It helps them to relieve the pain. You can just put it for their bathing and use it. Epsom salt, which are available in Amazon as well.
All right.
Avocados, again, a rich source of vitamin E, good fat. Hemp seeds, hemp milk as a substitute for dairy products because of the antibiotics and the hormones that are injected so much in them. So the benefits of anti-inflammatory diets, they are packed with vitamins and minerals. They are rich source of fatty acids and dietary fiber. They provide energy, and they are loaded with phytonutrients like flavonoids and carotenoids.
Okay. All right.
Thank you.
Gayatri, since you're already presenting, so can you tell me a little about FODMAP diet, in the sense a low FODMAP diet is supposed to be good for endometriosis. So can you just elaborate a little?
See, FODMAP diet is pretty tricky in the sense that it needs very efficient planning. FODMAP is very notorious for triggering symptoms of the digestive gut, where the major symptoms are bloating, abdominal cramps, constipation, belching, and all that. So, this is usually followed in severe case of irritable bowel syndrome, IBS, what we call. So, if there is severe case of endometriosis combined with IBS, then FODMAP diet, yes, it can, be helpful, because this FODMAP diet, it has a restriction of so many foods which are included in a daily lifestyle. So there are a lot of restrictions and exclusions, which becomes very difficult and annoying for patients sometimes. You to take it up as a challenge. So
to manage.
Yes, to manage, exactly. So if it is in severe case where it is associated with celiac disease or irritable bowel syndrome, then the FODMAP diet will definitely help. It is more like avoiding your fructose or galactose and lactose. So there are a lot of exclusions that I told you. Like some people have their staple food, so which they don't want to kind of give it away. So that is why FODMAP might not be a successful regime always. But whereas an anti-inflammatory diet is a more practical approach, for an endometriosis. Yes.
Makes sense. Something that's sustainable.
Correct. Yeah. Exactly.
Good. That's good. Dr. Sally, so can you is there something that you can demonstrate for pelvic pain, in the sense of some exercises or something that is there? Is there something that you would like to tell us about? I mean, you specialize in. Hello.
More than what I've already demonstrated?
No. I mean, you specialize in pelvic mobilization and myofascial release, right? So there is something. Is there something specific that you want to tell us about these particular things?
Well, I mean, I would say this. I would say that having pelvic PT before surgery is immeasurably valuable because you're able to work on that connection between the central nervous system, or how your brain recognizes the pain, and your pelvis, so that you're better set up to heal from surgery. And I think beyond that, that it's really important to work with a professional, whether you're working with them one-on-one or based on telehealth, to get exercises that work for your specific pain. So much like our nutritionist said that some people can handle soy milk and some people can't, some people can handle an exercise and some people can't. And it's really important, just like she specified the entire seminar, to be one-on-one with someone. And I also gave some resources for stuff that you can do at home.
Perfect. Perfect. That's perfectly fine. And is there something particular that you would want to tell the endo patients? You know,
I mean, like,
what is the giveaway that you would want to tell the endo patients? I mean, they go through so much physically and mentally that, you know, it's not just physical, it's mental also, because you go through so much of chronic pain all through the time. So is there something that you would want to tell them?
well, my take-home message always is that your voice matters, and that we, and even on the chat box, well, there's a whole bunch of questions, but I can't afford it, and I can't this, and I can't change that by myself. I need everybody with me. So it's not about sitting home and complaining, why is it like this? And about pointing fingers. It's about banding together and using your voices together to create change. That's the cardinal founding message of the Endometriosis Summit, that we want to move endometriosis forward, and we need everybody together to be able to do it.
Yeah, true. Thank you so much. And Dr. Seema, could you just tell us some alternatives which are available for women who cannot conceive naturally, okay? And how successful is IVF implantation when it comes to endometriotic patients?
So Shilpa, as I was mentioning earlier, this all endometriosis is an active and ongoing disease. So fertility is such a thing that here I wanted to mention, since Heather and Sally, they have just told everything, their experiences regarding repetitive surgery. So time, actually this is the century, and this part of the century we are learning what endometriosis is, how should it be treated. As Vimy pointed it out, that it should be a special self fertility. People are not as much trained, and their brain, whatever it doesn't know, cannot perceive. That's the reason. So these girls, the best time for them to be counseled about their fertility goals is the time when she was undergoing the first surgery. When she was 18, 19 years old or 20 years old, she should have been told about oocyte freezing if she doesn't have a problem partner. So this thing, fertility preservation, is a very important issue in a life journey of this endo patient, and it should always be given, and there should be a multidisciplinary approach, and there should be that fertility preservation unit nearby where it can be done. At least even if she's not willing, you have to tell her that realistic thing is that you might be suffering from repeated surgeries and frozen pelvis. These make things harder, and as disease progresses, fertility becomes an issue. So as I've told you earlier, if her age is on side, she's not having ovarian endometrioma, her basically pelvic tubo-ovarian axis relationship is normal, you have to give her time. We call it expectant management. That I'm just sharing my screen for a minute. So, sorry. So what happens, expectant management means you are at home and trying to get pregnant on your own. But if it doesn't happen, then you have to meet your doctor. You have to take into consideration that you have to go for active fertility management. And active fertility management, can you see my screen now?
No,
No?
no.
No.
Okay.
Uh,
Sorry. Okay. Okay. No problem. No, this is not the screen I want to share. It's not coming. Fine. Expectant management is something when you are trying naturally. Don't give long time for that. After 3 to 6 months, you have to meet your doctor. If you have not conceived, you have to look after other factors which are doing it. If there is nothing else than endometriosis, you have to go a step further, and that is ovulation induction. Ovulation induction we do with drugs like clomid, letrozole, but alone that is not very helpful, because these girls, they are ovulating, they are not anovulatory. So here if we add intrauterine insemination, as I was telling, that is a simple procedure where you take the sperm of the husband, semen of the husband, you wash it out and you just put it in the uterine cavity. So you make the chances of meeting these two gametes, egg and sperm, more than what normally is happening. Normally semen goes into vagina, and from there one sperm is just traveling through that fallopian tube, and you are making the increasing the chances of their meeting, and that has been shown helpful for them. And if 3 or 4 cycles of IUI is not working, if this girl has not undergone laparoscopy earlier, now is the time when she should be taken for the surgery. She should have been taken for the laparoscopy. And laparoscopy and fertility treatment, they should be taken as complementary to each other. That's why the recent, whatever recent guidelines are coming, because as we are understanding the disease, they are also favoring in excision, except for deep endometriosis. There are things, there are so many nerves and fibers and everything involved, that we are just avoiding deep endometriosis excision before this lady or girl completes her family. Otherwise, rest of the things, they are going to help her in gaining pregnancy, except for the repeated surgeries. And if IUI 3 or 4 cycle is not working, directly this girl has to go for in vitro fertilization, and it has been seen that it gives the best results for these ladies, if even if IUI and the rest of the things are not working. So IVF is a better option. You have to go in time. Since your disease is progressing, your ovarian reserve is good. If you opt for an IVF, that would be a better option for you.
So are there any particular complications which are associated only with women who have endometriosis, not with the normal people?
Exactly. So that's why I wanted to share the screen, but I could not. So
That's okay.
yeah. So endometriosis, there are few things involved. First of all, it is a pro-inflammatory condition. There are few hormonal disturbances happening, especially there is progesterone resistance. Along with those pro-inflammatory things, this progesterone resistance is causing some gene dysregulation, which hampers the implantation of the embryo inside the womb. And that is the biggest thing. So in the beginning of the treatment, when you are going to start, you just have to counsel the patient that results of IVF success in your case are going to be lower than your friend who is not suffering from endometriosis. Once this implantation has occurred, chances of continuation of pregnancies are very good. But still, as per 2019 report I was just going through, I am just using the word greater than your normal counterpart. Chances of miscarriages are 90% greater than any non-endometriotic patient. More than 30% chances of ectopic pregnancy. There are chances of preterm labor. There are chances of small for gestational age baby, low birth weight baby, and there are increased chances of cesarean section, gestational diabetes mellitus, and so many things. And one interesting thing, there were contradictory reports regarding like gestational diabetes, that is more in young girls suffering from endometriosis. Eclampsia pre-eclamptic toxemia. These are hypertensive disorders where pregnant lady starts having headache, her BP is high, and all those things. And these are happening because of there is abnormal placentation. There is not proper vascular supply because of this pro-inflammatory state. And there are so many unknown mechanisms acting here that all these factors, prematurity, low birth weight, gestational diabetes mellitus, and hypertensive disorders, they make them prone for having increased rate of cesarean section. So if we go about like 26 times more chances of getting GDM than a normal girl who is not having endometriosis. Similarly, stillbirth, sometimes they have stillbirths. And even if you're conceiving naturally, these things happen, especially prematurity and preterm birth. That is higher in endometriosis. So you have to tell the patient she has to, and since there is progesterone resistance, so all those medicines you are just pumping through in her body, that is not going to work properly. So maybe a time comes when people start advocating, get rid of your endometriosis first, get it excision done and everything, and then plan your pregnancy. You
Absolutely.
can never say anything looking at the complications rate. And whatever Gayatri was telling, all these diets and all the exercises Sally was telling, all these things are going to help. After all, your lifestyle, what you eat, how are you living, and that is basically, there is very huge influence of our lifestyle and whatever environmental changes, especially these disruptors and things, are affecting this disease, and that's could be a reason why it's increasing by leaps and bounds. So there are chances they are going to get pregnant. IVF is the best choice if it has been longer and you're not able to get conceived, but there are that little bit lower chances of success than your normal counterpart. Once you are pregnant, there are chances that you can get these complications, but not everyone. And most of my patients at this time in IVF, 50% are suffering from either adenomyosis or endometriosis, but they are doing very well. They continue their pregnancies, they are delivering. Yeah, cesarean rates are higher. I am not able to take that risk, but there are many people who are conceiving naturally, they are not having these comorbidities, they can deliver normally as well. They can be given a trial, but it all should be taken into consideration. Your doctor is the best judge, you have to trust her.
That's informative. That was quite helpful, actually.
Here I-
This there is one question which is open to all of you.
Before this, I will just like to add on to what Dr. Seema said. To improve the quality of life, the importance of yoga in endometriosis.
All these diseases, yoga and meditation,
Yes.
either it is through this relaxation or just decreasing the sympathetic overtone of the body.
Correct.
That could be a reason, because
Exactly.
what Sally is doing, she's trying to relax and inducing the parasympathetic pathway of nervous system, and through that it's working. So this yoga and meditation is doing the same.
Yes, because as very true, doctor, and what Dr. Sally earlier mentioned about the breathing exercise. So, pause breathing will definitely help, where they inhale and then they pause it for 5 to 10 counts, and they slowly exhale, and again they pause it for 5 to 10 counts. And there are certain poses or asanas in yoga which will definitely play a major role in easing out the pain, because it actually puts a pressure on the pelvic region, where and acts on the reproductive organs, and helps to ease out the cramps and pain, and improves the circulation, blood flow, basically. So
Actually, I have to say, just to interrupt you, that it's not everybody's jam to do yoga, and that there is research that there are many forms of exercise. This whole notion that if you want to help pelvic pain, you should do yoga is actually misproven in the research. There's a lot of research that shows that there's as long as you're exercising and you're attending to your central nervous system, it provides the same benefits. So if yoga, my goal is to get the patient to exercise because that's what's good for cardiovascular health and that's what's good for bone development. And that it's not only yoga, because I was a patient and if one more person told me to do yoga, I was going to roll my eyes in their face. And so I always make it very, very clear that it's not only about yoga. And that, yes, there are some yoga exercises that are good for pelvic pain, but there are also plenty of bar exercises that are good for pelvic pain. There are plenty of CrossFit exercises good for pelvic pain, believe it or not. There's swimming, there's walking, there's running, there's Pilates. Like, so we don't, right. I don't want to have to
not complete, not all the asanas, but only certain poses like squatting, forward bending, and sitting in Vajrasan, so these kind of
I mean, there's also plenty of the comorbidities that come with endometriosis that yoga is not good for. So I don't like to put people in the box of you only need to do yoga and breathe, because the point is you need to do something. You can't lay in bed and think that endometriosis is going to be solved. Correct. I don't care if you march in front of the TV, but it's not only about
completely agreed. As long as you are exercising, you are doing well. And this is a field of specialists who can design those poses and forms which are better. And we are not recommending only yoga. Yoga is also a form of exercise which can be beneficial. That's what I wanted to say. And it is up to someone who is specialist in that. That person can only tell which one. But meditation, breathing exercises, they provide you oxygen. They are cleansing your body as long as it's fine.
So one question for all of you out there. So a lot of heavy periods and severe cramping. So is there something, how should a person manage the pain? Because I think 90% of women here have pain,
Can you repeat that? Because you cut out halfway through.
Hello?
Can you repeat, Shilpa, because your connection was not there?
Okay. What I was saying is that 90% of women who are actually joining this forum right now have complained of pain. All right. So is there some particular way in which they can manage pain? Excision surgery, all right, if endometriotic excision surgery is the thing. But in the meanwhile, if they're having pain, is there something that they can do?
Well, I don't think anybody here wants to or is permitted to give specific medical advice, of course, but I think we've talked about a number of different things. There's pain management, there's mindfulness, there's alternative therapies, there's pain medication, both narcotic and non-opioid. There's obviously pelvic PT is critical. Diet, exercise, nutrition. I think we've kind of given a whole gamut of things that work before and after excision surgery, but really it is about the patient and what works for them individually. And sometimes it's a process of elimination and sometimes we don't know. That's just the reality of this disease. There's no box we can give somebody that says unpack this, and on Tuesday you take this pill, and on Wednesday you're going to do Pilates, and Friday you're going to eat a green salad and you're going to feel great. It's not that way. It's all of the things go into the box. The whole armamentarium comes out, and you use what you have and you do the best that you can. And you would hope that you can get to the proper surgeon who is going to excise deep disease, superficial disease, ovarian disease, who's going to take away adhesions and do all of the physical components. And hopefully you'll be continuing those adjuncts because, like I said, they work well before and after.
Absolutely. So the main thing is finding the right doctor for yourself.
Absolutely.
So that's what.
Shilpa, not every girl who's having painful period is going to have deep endometriosis. Every girl doesn't need surgery. So she can be put on any symptomatic treatment along with, as Heather told, mindfulness, something else. But if all these things are not working, she is not a case of advanced stage of disease, a 13-year-old is not undergoing an excisional surgery. You can put them on pills continuous for a few months, or there are therapies you can put and try it before going for anything else, unless it is something which now you have to intervene actively, I think.
I mean, my 13-year-old niece, we call her, was not able to attend school without an excision surgery. So there are those cases.
You have to diagnose first. You have to diagnose it and label it.
We would prefer that they hormonally mature before doing surgery. Absolutely. So the answer to the question from my perspective is that you have to be engaged in your own care. If you're on the couch and you're in pain and all that you can manage that day is to make one good choice about what you're putting in your body. So today I'm in a ton of pain and all I'm going to do is watch 90 Day Fiancé, but I can make a choice that I'm going to drink more water, or I can make a choice that I'm not going to eat cakes and cookies because it's inflammatory, or I'm going to make a choice that I'm going to walk up and down the stairs instead of taking the elevator. Or I'm going to make a choice that I'm going to use my hot pack, or I'm going to take my medical marijuana. Or you have to be engaged in your own care. And then when you're not in that much pain, what's the next choice that you can make? I can make a choice to go to a doctor who's going to discuss with me, will this birth control cover me symptomatically? Will I be able to take this non-steroidal anti-inflammatory? We never even got to suppositories for the pelvic floor. Do I need something like that? Do I need pelvic injections? Do I need surgery, right? What's the next choice? You kind of have to go from choice to choice to choice. And there has to be a sense of, like, it can't all be doom and gloom. If laying in bed and watching 90 Day Fiancé, do you even have that in India while I'm going on stuff? But if laying in bed and downloading Hamilton on Disney, if that's what brings you joy in that moment, you have to embrace that, because the pain is not going to bring you joy. And you have to accept, this is where I am in this time, in this snapshot of my life. And in the next snapshot, I'm able to move forward to something else. And then the other thing, I mean, obviously, that everybody needs to do is to attend the Endometriosis Summit, because that is like the most empowering experience you ever could have. Sorry.
You have to control what you can control. You cannot control the things you can't control. It really does come down to that. And I know that seems, kind of empty and hollow, but I lived it, so I do know. The more that you empower yourself, the stronger you will become.
So the social worker for the Endometriosis Summit, Casey Berna, who is very involved in the United States in our standards for care argument, she says, control the controllables. So if you're in a day and the pain is too much, your family's having a barbecue and you're like just out of it and you can't handle it, there's nothing there you're going to be able to control. Right? You have to find that's honestly one of the reasons why I like diet and exercise, because those are things you can control, but you control the controllables. You can't do more than that. And you can't have that expectation on yourself. You can't have the expectation that your adenomyoma is magically going to be excised in that afternoon where you're in pain. You can only control the road that you're living. And in the US, I'm not sure the system in India, we have a lot of trouble with control the controllables, because insurance wants to be in charge of care, and pharma and the standards of care want to deem what's right for endometriosis, and it isn't. And for those that are trapped in that prison, I encourage you to get involved and to be empowered and to use the avenues that are out there to help you be empowered over those things.
Perfect. I think that was like fabulous. That was a lovely take-home message for all of us who are fighting with endo. So it was an extremely informative session. Do we have time to take questions and answers?
Most of the questions were answered by Sally and Heather. So thanks a lot to both of them.
Oh, that's so amazing.
I tried to answer.
Some of these were intentionally ignored because they're asking for specific.
They are asking PCOS and other things which are not related to our topic.
Yeah.
One question, one girl mentioned that she wanted to discuss mental health related to the pain and what medications they are going through endometriosis.
Yeah, and I think we talked about that a little bit. I think mental health is a key component, just like anything else. you know, I mean, this is a team sport. Let's face it. You know, yes, you need a gynecologic surgeon, but like someone like me, I needed a high risk reproductive endocrinologist because I was very, very sick throughout my pregnancy with endo related situations. You need possibly a nutritionist to help guide you. A health coach, if that's you know, something that you're into. You need your physical therapist. You need your mental health professional. And I know that there's a lot of stigma and a lot of shame, particularly when we say, oh, we have to be strong and we have to fight and we have to do all of these things. It's not a sign of weakness to add the mental health component to your well-being. It can only help, especially if you can connect with someone who specializes in chronic diseases, and they exist, and or women's health, as the case may be. You know, these are professionals who make up your army. That is your team. That's your home team. And I think if you're dealing with the effects of medication induced depression, or like in the case of Alyssa, you're having suicidal ideations, you absolutely must see somebody, and you also should reevaluate whether or not you should stay on that drug if it's right for you.
Absolutely.
That's right. So Dipti has one question. She's asking how effective is treatment for people with underlying.
Shilpa, your connection issues, so please repeat the question. Okay, I would say that question, Deepthi has asked, how effective is the treatment for people with underlying disease like diabetes or blood pressure?
How effective is treatment for people with endometriosis who have a comorbidity of diabetes or hypertension?
Yeah.
I don't know that we have, I don't know that there's a real answer to that. You know, they're not known comorbidities specific to endo, like a fibroid, like an adenoma, like, you know, other pelvic pain gynepathologies. I think both need to be managed clearly. And I think that you need to work with your respective specialists to make sure that you're not contraindicating one treatment for another. But I will say, in terms of being a type 1 or type 2 diabetic, if your doctor is recommending certain nutritional approaches as part of your lifestyle for management of your diabetes, that tends to be, you know, an elimination of processed foods or high fatty sugary foods. That might also help endo, but I don't think we can talk about diabetes treatment and endo in the same. I
think choice of treatment for endometriosis will remain same even if the comorbid conditions are there, and that have to be dealt with the specialties, like endocrinologist has to be involved and a physician has to be involved. That's all.
Absolutely.
There is no change in the mode of treatment for endometriosis.
I mean, the only thing we would do differently is if you needed insulin, we would have you bring it to your surgery.
I think that's a medical management of comorbidities. The choice of treatment for endometriosis remains the same.
Exactly. Yes. Mm-hmm.
And somebody is asking, am I audible now?
Yes.
I hear you.
So somebody is asking, my tummy and back hurts after I eat a meal post my surgery. Does this involve endo-related issues?
It could be a 9 million.
Some of them be ignored on purpose.
I mean,
we can't say
how
that.
close
Like,
to surgery was it? If you
when the surgery was done, how many days it is post surgery? So many things are there.
Yeah,
I mean, I was operated on a year ago. I still have colitis from the surgery. I mean, so like we can't say, you know, we can't offer medical advice.
Absolutely. So what I would suggest the audience is, we will get back to you whatever is related. Medical advice is something that we can't directly give on, you know, on a webinar. It's better to connect up with the doctors, and then we can, you know, then you can proceed with it. Rest of the questions, we will, you know, answer you the questions in the, you know, in the.
I think most of the questions have been addressed.
Most of them have been. And
related to endometriosis.
In case there are still queries, you can please post them on our Endo Crusader page. We will be happy to answer. So it was like a beautiful session. A lot of my questions for sure were answered, and I think the same has gone with the audience.
I hope so. I really want to commend you for what you're doing. I mean, there's a lot of awareness about endometriosis. Not all of it is right. In fact, most of it is wrong. So it's really, really encouraging and inspiring to see you bringing together panels and putting out information that can help so many people, not just local to you, but really, internationally. And it's an honor. So I want to thank you all for
you.
allowing us to take
I
part.
must thank all of you for joining us and readily agreeing to come to
Absolutely.
India as well.
We show up anywhere. If it's about endo, we're there.
Yeah, we don't
Thank
care.
you.
We're old, right?
Thank you,
I always
women,
tell
for
the story.
involving us in this.
To the person.
Thank you so much for joining.
Thank you
Thanks
so much.
to
Thank you so
Gayatri,
much.
thanks to
Let's-
Thank you,
Pratima,
Catherine,
Sally,
Sally, for
Peter,
such a
and Shilpa was
Yep.
she was a very good moderator today.
Thank
Yes.
you so much. And I think it's time all of us, join hands together and fight against this silent